So if you're a dedicated healthcare provider, maybe a physical therapist, a mental health specialist,
Speech language pathologist, yeah.
you are sitting on this massive opportunity right now, and it's almost all driven by the explosion of telehealth.
Hmm.
You can serve patients far beyond, the physical walls of your clinic, but there's a catch.
A huge one. A massive, frustrating wall of bureaucracy standing between you and that expansion.
We see you. We
Mm.
really do. You want to serve more patients, but compliance feels less like an admin task and more like a full-time job for a whole army of
It
lawyers.
absolutely feels that way. I mean, the sheer volume of applications, the overlapping rules,
Hmm.
it's enough to stop an expansion cold.
Exactly. And that's why this expert guidance we're looking at today is so important.
It really is. It cuts through all that noise and tells providers exactly where the critical tripwires are.
So our mission today is to dive deep into this source material and really just distill the essential, non-negotiable steps you need to follow to maintain compliance and avoid those truly costly errors.
Errors that can sink a whole expansion plan before it even gets off the ground.
Because the core problem here, and the source puts it perfectly, is that you're navigating a patchwork of licensure and enrollment rules.
That patchwork analogy is so good because you can't just throw one blanket of credentials over every state.
Not at all.
The fundamental rule right out of the gate is duality. Providers have to be licensed and enrolled in programs in each state where they practice.
Okay, and that separation, that's the key distinction we have to unpack first.
It's the absolute critical starting point.
Let's do it then, because this is where the terminology trips up even seasoned professionals. We're talking licensure versus credentialing.
Hmm.
They sound like they could be the same thing, but they govern two completely different permissions. What's the real difference?
Well, the fascinating thing is that they serve totally different masters.
Okay.
Licensure. That's the state's permission. It's a legal thing issued by a specific state board
Hmm.
that says, yes, we've checked you out, you're qualified, you can legally treat patients here.
So it's like your professional driver's license for that state.
Precisely. That's your permission slip to drive on their road.
Got it. So what's credentialing?
Credentialing is the payer's process. This is where the insurance company or a government program like Medicaid does their own deep dive on you.
Their own background check.
Exactly.
Yeah.
And they enroll you into their specific network. This is the part that lets you submit a bill and, actually get paid for your work.
Ah, so if licensure is the driver's license.
Then credentialing is the payment card that lets you actually run the business of seeing patients.
Okay, so you need the license to legally do the work, and you need the credentialing to legally bill for that work.
You need both. Operating at the same time in the same state to run a compliant business.
And this gets even more complicated with telehealth, right? The geography of it all.
Oh, absolutely. Our source material really hammers this point home.
Yeah.
For telehealth, the practice is almost always considered to happen at the patient's location.
So it doesn't matter where I am.
Nope.
Hmm.
If you're in your office in Texas, but your patient logs on from their house in Oklahoma, you're practicing in Oklahoma, and you need an Oklahoma license or some kind of specific telehealth approval.
The digital revolution didn't get rid of state lines.
It just made them follow the patient.
Wow. The second that patient opens their laptop in state B, you are officially practicing in state B.
That's the rule.
And that just sets up the sheer administrative weight of managing all of those different state Bs. Starting with licensure, you have to verify you hold the right permission in every single state where you have patients.
The burden is staggering. Now, the source does mention some rare exceptions.
Like what?
Like some states might allow for a very short-term, temporary practice for continuity of care. If a longtime patient is visiting family out of state for a week or something.
But that's the exception.
Absolutely the exception, not the rule.
Yeah.
The general rule is always patient's location dictates your license requirements.
This sounds unbelievably burdensome. I mean, every new state is a new application, new fees, new forms. Is there any way to make this easier?
There is, and this is a huge aha moment for providers. The source introduces these things called compacts.
Interstate compacts, okay?
And it positions them as a critical simplification tool. They're basically contracts between states that make it way faster for a provider licensed in one member state to get the privilege to practice in the others.
And the source mentions a couple of big ones.
Yeah, specifically the PT Compact for physical therapy and the SLP Compact for speech language pathology. They cover dozens of states.
So how does a compact actually reduce the administrative load? Does it, like, get rid of the application?
Not entirely, but it streamlines it dramatically.
Yeah.
Instead of filling out 10 full original applications for 10 states.
Which would be a nightmare. All the transcripts, background checks.
A total nightmare. Instead, you submit one application to the compact, and you get back what's called a privilege to practice for all the other member states.
So you're going from months and months of paperwork down to a single centralized process.
Exactly. For licensure, it's a game changer for speed and efficiency.
Okay, so the compacts take a huge slice out of the headache for licensure. But now, the payment side.
The Medicaid hurdle.
Right. Which often remains fiercely state-specific.
This is where that complexity just digs in. Even if you get your licenses through a compact, you still have to enroll separately with each state's Medicaid program.
And all the private insurance networks, too, I assume.
Every single one.
Wow.
And here's the fact that is worth repeating because it's the most common mistake. There is no universal Medicaid credential.
That's just a staggering logistical reality for any practice trying to scale nationally.
It is.
It means while Medicare is federal, Medicaid is essentially 50 different unique payers.
That's exactly it. You have to enroll in each state where you treat Medicaid patients. And these aren't just, small variations. They have different criteria, different provider IDs, different websites.
It's a whole new system every time.
The source confirms this is the primary bottleneck, especially for practices serving lower-income patients across state lines.
Now that we've highlighted that difficulty, let's pivot to the federal side and talk about one of the few areas where things are simpler: Medicare.
Yeah, and the comparison is really valuable. While Medicaid is totally decentralized, Medicare enrollment is federal.
Okay, so what does that mean in practice?
The source confirms that once a provider is enrolled in Medicare, they can actually bill Medicare patients in any state.
Now that is the simplification we were hoping for. So how does that work?
It's tied to your NPI, your National Provider Identifier.
A 10-digit number.
Right. It's your unique federal ID. Once you're enrolled in Medicare using that NPI and you've listed all your practice locations with CMS, you are good to go nationwide for Medicare patients.
That centralization is such a huge relief compared to the Medicaid mess.
It is. But there's a key compliance note the source brings up. It's not a huge deal, but while the authorization to bill is nationwide, providers must still update their federal enrollment if they open new physical offices.
So you have to keep your address book with the government current.
Basically, yeah.
Yeah.
Not doing that can lead to billing errors or, worse, flag you during an audit.
Okay, so we have the Medicare exception. But for Medicaid and private insurance, we are stuck with state-by-state applications. Which brings us to the waiting game. You're licensed, your application is perfect, you hit submit. What's the real timeline someone should be bracing for?
You have to be realistic and conservative. The source says to typically allow at least 1 to 3 months.
A month to 3 months.
1 to 3 months for a complete enrollment after you've submitted everything. That's up to 90 days.
Wow, 90 days of downtime where you cannot bill even if you're licensed and seeing patients.
Correct.
Why does it take so long? I mean, what is happening behind the scenes for 90 days?
It's not arbitrary. It's built into the system. 2 big bottlenecks. First is what they call primary source verification. Right. The insurance network is legally required to check every detail, your education, your work history, your licenses, directly from the original source. That's a manual process.
I see. And the second bottleneck?
The credentialing committee. Every new provider enrollment has to be reviewed and approved by a formal committee, and these committees, they usually only meet once a month.
Oh, no. So if you miss the deadline...
You automatically wait another 4 weeks just for them to look at it. And that's how you get to that 2 or 3 month lag.
That makes the advice so much more actionable. It's a structural delay.
Exactly. Which means providers have to start this process way, way before they plan to see patients.
Yeah.
You have to factor those 90 days minimum into your business plan.
Because you can't bill until it's done.
And if you assume it'll be faster, you risk sinking a ton of money into a state that won't generate any revenue for a whole quarter.
Which sets up our final big segment. What happens if you mess this up? If you try to bypass that 90-day wait, or you just lose track of a renewal, what are the consequences?
They're immediate, they're financial, and they're severe. The source is very clear. If you aren't properly credentialed in a state, any claims you submit from that state will be denied.
Just flat out denied.
Flat out. That's non-recoverable lost revenue. Gone.
And lost revenue is one thing, but does billing without enrollment open you up to bigger problems?
Oh, absolutely. It's a regulatory violation. It exposes your clinic to serious actions, including huge financial penalties or these deep dive audits.
And an audit in one state could trigger reviews everywhere else.
It can. It's why operational discipline is just non-negotiable as soon as you go multi-state.
Which brings us to the big operational imperative. Centralized tracking. You just can't scale a practice using sticky notes and spreadsheets.
No way. Centralized tracking is the essential strategy. You need one single specialized system, not just a shared doc, but real software to track all these critical dates.
State licenses, Medicaid, Medicare.
DEA registrations, private insurance contracts, all of it.
Why is centralizing it so important beyond just being organized?
Because of that timeline we just talked about, the goal isn't just to know when a renewal is due.
It's to get a heads up.
A big heads up. It's to set automated reminders that give you 3 or 4 months of lead time. If recredentialing takes 90 days, your alarm needs to go off on day 120. That's what prevents those missed renewals and devastating claim denials.
And this isn't a set it and a forget it kind of thing. Regulations change all the time, right? Especially with telehealth.
All the time. You have to treat regulatory awareness like a continuous line item in your budget.
So where should a provider be looking for updates?
The source points to a few authoritative places. You have to monitor CMS updates for Medicare. You have to review the state Medicaid manuals, which are often huge, and use telehealth policy resources.
So it's an ongoing job.
It is. The good news is that HHS, the Department of Health and Human Services, they actually encourage using those licensure compacts to streamline things. But you still have to actively watch for the rule changes.
What a dense but necessary deep dive. Let's wrap up the 3 biggest takeaways for a listener who's trying to expand their reach right now.
Okay. First, get the distinction right. You need state licensure to practice legally and separate credentialing from the payer to get paid. 2 different battles.
Got it. Second takeaway.
Remember the fragmentation rule. You have one big simplification. Medicare is federal.
Enrolled once through your MPI.
Right. But for every other payer, especially Medicaid, compliance is always state by state, no shortcuts.
And the third.
Compliance is a proactive operational strategy. You have to use a centralized tracking system for all your dates and set those reminders with a minimum 90-day lead time. That protects you from denials and audits.
Okay, so here's where it gets really interesting, building on everything we've just discussed. If you're planning an expansion, you now have a really tough strategic question to answer. Should you prioritize states based on how easy the licensure is, like joining the PT or SLP compact and just targeting those states? Or should you prioritize states that have the most profitable private payers? Or maybe states where Medicaid rates are good, even if the enrollment paperwork is a complete nightmare?
That 90-day enrollment timeline forces that choice. Do I follow the path of least resistance on licensure or the path of greatest financial return on the payer side?
Because you probably can't have both everywhere.
Not easily.
Absolutely. So we suggest you take this knowledge and immediately go look up the specific membership list and rules for the compacts in your field, PT, SLP, whatever it is, and then map that list against the Medicaid manuals in your target states.
That dual strategy is the only way to turn the administrative cost of all this into a real strategic advantage.
Knowledge applied is power gained.
Well said.
Thanks for joining us for the deep dive. We'll see you next time.